Good afternoon, everyone. Thank you for joining us at Medical Grand Rounds. Just a reminder before we get started, we will ask you to please answer a brief survey at the end of the presentation. This will let us know that you were here today. And we'll ask you to leave questions till the end and to enter them in the chat. It's a great pleasure to have an outside speaker today, Dr. Cornelia M. Weyand, MD, Ph.D., who's coming to us as a professor of medicine and immunology at the Mayo Alix School of Medicine and as professor emeritus of medicine at Stanford University School of Medicine. She has recently taken on the directorship of the program in immunity and inflammation, a program in translational immunology embedded into Mayo Healthcare System. Dr. Weyand is a physician scientist with a special interest in autoimmune and chronic inflammatory diseases, including rheumatoid arthritis, large vessel vasculitis, and atherosclerosis. Over the last decade, she has devoted special emphasis to remodeling of the immune system with aging, how chronic disease ages with the immune system, and how aged immune cells caused inflammation. She is known for having defined molecular defects underlying the premature aging process in patients with RA and has discovered mechanisms through which aging confers susceptibilities to giant cell arthritis. Her bio is long and very distinguished, and I'm going to stop there because we want to really hear Dr. Weyand's presentation today. So welcome. Thank you so much for being present today. And the floor is yours, Dr. Weyand. Thanks for being here.
Thank you very, very much for giving me the privilege to be there today at McGill. And I would like to share some insights with you on how we understand disease pathways in vasculitis. We will focus on giant cell arteritis as a model system. But to open up, I would just like to show a Canadian-American collaboration. You know that Canada, the Europeans, and NASA worked together to put the Webb telescope into space. And the Webb telescope has given us these incredibly beautiful pictures. And at the same time has showed us some humbleness, what it means, you know, to be on Earth and just try to do our best in understanding nature and nature's rules. So how has the landscape changed in our understanding of large vessel vasculitis? Well, this is a quintessential autoimmune disease that, interesting enough, attacks the large vessels, the aorta, and its large branches. So how does autoimmunity occur in this very unique space? The world of autoimmune disease has, of course, made the transition to go from tissues to cells, to organelles, and to molecules. And of course, we want to understand disease at the level of the molecule. So I'll show you what has happened in terms of large vessel vasculitis, how this has happened, and where it has happened. Of course, there has been enormous progress in immunology. We understand the immune system, the human immune system, much better, and that has had its impact on understanding autoimmune disease. And finally, the pandemic has taught us important lessons. So we used to think that to make an immune response, all what we needed was antigen and go signals. We thought that when the immune system recognizes antigens, that then there would be induction of an immune response, of a good protective immune response, or in the case of autoimmune disease, of a bad one. We now know that there is major modulation of this process by both co-stimulatory as well as co-inhibitory signals. And this we have learned from our colleagues in cancer immunology. They, of course, have told us that there is not just a T cell recognizing antigen making an immune response. No, there are shaping forces in the form of go signals and stop signals. And in cancer immunotherapy, we do disrupt the stop signals to unleash the immune system of the patient. What we have also learned is that the outcome of an immune response is a high variety of different T cells that are then appearing as effector T cells, memory T cells, regulatory T cells, stem-like T cells, exhausted T cells, and tissue-resident T cells. And I'm sure that this list is not even finished, that we will, as we learn more, we will have broader, deeper insights into what the outcome of an immune response can be. Another important lesson that we have learned, and here the pandemic was instrumental in teaching us, we always thought that protective immunity is there to defend us against cancer and infections. And we thought that there is pathogenic immunity that gives us autoimmune disease. Well, what is very clear now is that humans only have one immune system, that the parts of protecting and the parts of attacking are coming from the same immune system, that we cannot separate protection and disease induction, and that our immunosuppressive therapies dampen autoimmunity, but they also dampen the defense against infection and cancers. And I think we will spend the next decade in the management of autoimmune diseases all over the organ systems in trying to figure out how we can hit a much better balance between not destroying protection, yet managing disease. So do not take it away too much. Don't make the cure worse than the disease. What are the cells, the molecules, and the pathways that are now dominating our understanding of the field of large vessel vasculitis? A major insight that occurred in the last decade is that a disease like giant cell arteritis has two major components. It has autoimmune features that are related to misfunctioning of the adaptive immune system. They lead to the inflammation in the blood vessel wall. We now call this the vascular GCA. There is another component of disease, which is autoinflammatory in nature. It's related to misfunctioning of the innate immune system. It leads to a systemic acute phase response. It leads to the extravascular manifestations of vasculitis. And what we are learning now, literally every day, is that these two parts of the disease are not necessarily going in parallel, but that they may have different trajectories, that we may need different diagnostic procedures to see them, and that we may need to have different therapies to treat them. You are very familiar with the vascular part of giant cell arteritis. You know this is a vasculitis that has a distinct tissue tropism. It goes to the temporal artery. That's where we take a biopsy to make the disease. It likes to go to the ophthalmic artery, and that, of course, puts our patients at risk to develop blindness. It goes to the vertebral artery and the subclavians and the axillary arteries. And we now know that almost all patients in the course of their disease will have manifestations in the aorta. There is a preference for the thoracic aorta. But as human beings live longer, we see how the disease literally moves from the ascending aorta to the arch, down into the descending into the abdominal aorta. You're also very familiar with the extravascular manifestations of this disease. Clinicians often call this polymyalgia rheumatica. It's a syndrome of muscle pain and stiffness that infects the shoulder girdle and the pelvic girdle. Patients can present with fever of unknown origin. They almost all have anemia, and they can present with failure to thrive, which then initiates and triggers the clinical machinery to make a diagnosis. The feature, and the one that is visible to us, is an acute phase response that goes with these extravascular giant cell arteritis features, and we can measure it easy in the form of a sedimentation rate and in the form of elevated CRP. So where does extravascular GCA occur? Well, there are two organ systems who are almost certainly involved, although a final proof has not been done. We now believe that the bone marrow transitions from steady-state hematopoiesis into emergency hematopoiesis with a high myeloid cell output and cytokine production, and that the liver responds to this with acute phase responses that produces the sedimentation rate and the CRP. Therapeutically, we can disrupt this by blocking IL-6. Unfortunately, when we do that, we do really not hit that vascular part of the disease. What is the vascular part of the disease? Well, this is a granulomatous inflammation, and it really occurs in an immunoprivileged niche. Granulomatous inflammation means that the dominant cell types that are sitting in all three layers of these arteries include T lymphocytes, macrophages, and then, of course, our patients can form giant cells coming out of these macrophages. To understand what the nature is of that inflammation, how the inflammation gets there, what it does to the artery, how the artery responds, we have depended a lot on a model system that I would briefly introduce to you. This is the immune avatar. It's creating human disease in human tissues. So we have bioengineered a little mouse in which we engraft human arteries. And then that mouse carries for us these human arteries. We can now reconstitute that mouse with human immune cells. This is why it is called the avatar. Human myeloid cells, dendritic cells, T cell, B cells, and really mostly designer cells, so that we can actually introduce into that immune system particular forms and functions of immune cells. That mouse then becomes a mouse that has vasculitis, and we can treat it. We can inject antibodies, small molecules, cellular therapy, etc. And of course, we can harvest the tissue and then look at the tissue on the tissue level. Where is which inflammatory cell sitting? What are they doing there? How are they functioning? And how does the tissue respond? So what do we know about the pathogenesis of giant cell arteritis? In the last decade, there has been a refinement in our understanding of the risk determinants. You all know that there is HLA association that's known for about 30 years. What is relatively new, and it has come from our colleagues in Sweden, is the understanding that patients that develop giant cell arteritis decades before they ever develop giant cell arteritis, so in the pre-disease period, have low blood glucose, low triglycerides, low cholesterol, and a low body mass index. So this is one of the few diseases where actually low glucose and lipids and low body mass index is a susceptibility factor for disease.
Yes.
We know that this then transitions into a pre-GCA period, and this is associated, we have called this checkpoint number 1 when this transition occurs. This, of course, is associated with a loss of self-tolerance. Here is when autoimmunity begins. What we clinically see in that pre-GCA period are patients that have polymyalgia rheumatica, and you know that they may or may not transition into vessel wall inflammation. To make that transition from the pre-GCA period into full-blown GCA, the transition from PMR into GCA, the tissue needs to lose tolerance, the tissue needs to lose protection, and to allow the immune system to actually go from the periphery into the vessel wall. Arteries are very well protected. So this is a significant step in the disease process. At checkpoint number 3, now vasculitis develops, and it leads to progressive tissue destruction. And I will try to tell you today what we know about these different checkpoints, what we have learned in terms of the immunopathology of the disease, so that an at-risk host transitions into a pre-disease period, then that transitions into vessel wall invasion, and that then transitions into full-blown progressive vasculitis. A critical element of checkpoint number 1 is a failure in regulatory T cells. And I will make an effort to keep the molecular details as limited as I can. But on the other hand, of course, I owe it to you to tell you what the molecular mechanisms are that are underlying. So it is now clear that humans possess a population of regulatory T cells. These are T cells that keep inflammation and immunity down, of the CD8 subset, that these regulatory T cells function by releasing exosomes that contain the enzyme NADPH oxidase 2, that these exosomes travel to CD4 cells and inhibit them in their function. This happens in a spatially restricted place. These cells need to sit next to each other for this to happen. We do know that patients that have a diagnosis of GCA have less of these cells. You can see here, when we isolate them freshly out of the blood, about half as many. And you see here that if we create them in tissue culture and expand them, that they are still about half as efficient as the age-matched controls. Well, we can go into the avatar and now test in the avatar whether such regulatory cells have a place in letting disease appear or not appear. Are they involved in controlling the disease? So you look here at the tissue section. We have stained for tissue invasive T cells. You see if there are no Tregs infused into the avatar, there is pretty intense tissue inflammation. If we put healthy Tregs in there, we can control and prevent that inflammation. You see, if the Tregs from the patients go in there, they are not capable of keeping the disease down. Why do they fail? Well, they have an abnormality in their signaling apparatus, which we have localized to the molecule Notch4. You see here that in the patient's Treg cells, there is aberrant and high expression of Notch4, which signals into the nucleus to induce a protein that's called HES. So this is a Notch4 dependent protein. And you see here that the patient cells have about, double as much of Notch4 signaling apparatus, and they signal and produce HES in an aberrant and intense way. So is it true that Notch4 is now regulating how these Treg cells work? Well, I'll show you here. If we take control Treg cells and we put them into the avatar, you see that they can keep down vasculitis. If we actually take healthy, good Treg cells and we overexpress in them the Notch4 signaling apparatus, then disease appears. If we vice versa take the non-functioning Treg cells from the patient, we have disease spontaneously. But if we knock down the Notch4 signaling pathway, we can nicely suppress inflammatory activity in this vascular lesion. So How does this happen? Well, this happens by the Treg cells actually utilizing their intracellular machinery to build vesicles and release them to the surface. So in a healthy Treg, what happens, the enzyme that has to go into the exosomes to suppress is being taken up by the early endosome, packaged into the late endosome, and then this makes NOX2 containing exosomes, which are the suppressive element. And this happens in a healthy Treg because there is no Notch4. And all of the machinery that packages and creates these exosomes and releases them is intact. In the patient's Treg, what actually happens is that the enzyme comes from the surface, is kept in the early endosome, is actually put into the recycling endosome, and is retained in an intracellular compartment. It doesn't make the transition into the late endosomes, and the exosomes are not formed. Notch4 controls the transcription of critical molecules that regulate this machinery. So the Notch4 signal really regulates how much intracellular vesicles the Treg cell has, how it is packaging the elements that it normally releases, and how efficient it is in releasing immunosuppressive exosomes. So this CD8 Treg loss of function in GCA patients occurs in secondary lymphoid tissues. It's early in the disease process. It causes an escape of peripheral CD4 T cells from containment. So natural brakes in the immune system are failing. It enhances the recruitment of pathogenic T cells to the vessel wall. And Notch-induced rerouting of intracellular vesicle disrupts the exosome production so that the Tregs cannot work well. Here is obviously an opportunity for us to not only utilize these Tregs as a biomarker, but can we therapeutically influence what's happening? The Notch pathway is important in these patients, not only on the regulatory T cells. Part of checkpoint 1 is the fact that in the blood of patients that have a diagnosis of GCA, there is a separate populations of CD4 cells that are positive for Notch1. So this is really a Notch family phenomenon. And this population of cells, and here we used a flow cytometry to show them, are indeed signaling, because we can see that the cell begins to produce the HES1 that is a target protein of that pathway. Where is that important in the disease process? Well, the ligands for Notch1 are appearing on the endothelial cells of the vasa vasorum. So when the disease makes the transition to go from the blood into the vessel wall, it does so through the vasa vasorum. And what you see here, we're here in the aorta, and we are here in the temporal artery, and we are looking in healthy individuals and in the diseased tissue samples for the expression of Jagged1. This is the molecule that connects to the notch. And you see here that a negative artery has no Jagged1 on the vasa vasorum, that the GCA positive temporal artery has plenty of it, that the aorta has plenty of it. This sits in on the luminal side of these vasa vasora and gives these T cells that are in the periphery the opportunity to actually crawl into the tissue space. We do know what the signal is that upregulates Jagged1 on these endothelial cells. That signal is VEGF. It is well known that patients with giant cell arteritis expand their plasma VEGF pool, and you see that that leads to an upregulation of jagged on the surface of endothelial cells. Is this disease relevant? Well, if we go into the avatar and we give the avatar vasculitis, and we actually inject that avatar with VEGF, we can surely amplify the vasculitic response. And you see that here in the tissue section, you see how aggressive that inflammation is when we actually inject into the avatar VEGF. We can treat the avatar by blocking the VEGF signal with axitinib. And so VEGF is certainly involved in a mechanism that amplifies disease. So where are we here in this pre-disease period and the transition? We have a predisposed host. We go into a pre-disease period. I showed you that these patients have poor T regulatory cells. They have inappropriate activation of the Notch1 pathway on T cells, and they have leaky vasa vasorum because these inappropriately activated T cells find a ligand on the surface of the vasa vasorum. So what happens when the disease makes it into the tissue? Well, this shows you a temporal artery, and you see how the artery responds to that inflammatory attack. You see that the artery really has no lumen left, and that's exactly, what is at risk when our patients develop this disease. This is why they get a stroke and in their optic nerve, why they get ischemia into their optic nerve and then become blind. You see that the inflammatory cells, and here are the lymphocytes coming from the vasa vasorum of the blood vessel, penetrate into all layers of the wall. You see here a patient that had the ascending aorta already replaced, and the surgeons have put in a graft. You see how they have clipped the residual native aorta to that graft. You also see that the aorta of that patient needs more attention. And by now, she had a replacement of the descending thoracic aorta with very, intact vasculitis in this tissue. So really, in the branches of the aorta, this leads to a vaso-occlusive event. In the aorta itself, it leads to dissection and aneurysm formation. How much disease is in that artery? How long does it last? And when we treat them, does it go away? So we approached that question with the dual biopsy study. We made a diagnosis by temporal artery biopsy. We collected tissue and blood at the time. We started to treat these patients with high doses of corticosteroids. And they got the Mayo Clinic treatment with corticosteroids. And then we aligned 40 patients to have a second site biopsy on the alternate side. If they had a left-sided temporal artery biopsy for diagnosis, we biopsied the other side after 3, 6, 9, or 12 months. We sent this to pathology to ask them a simple question. Do you see any vasculitis in this tissue? I can tell you the pathologists were blinded to knowing whether this is a pre-treated patient or not. This is the outcome of that study. You see that after 3 and 6 months, almost all of the patients have active, vivid vasculitis in the second site biopsy. That was not so surprising to us. The 6 months were surprising, but the 9 and the 12 months were the surprising part, because half of the patients remained positive. Now, don't forget, we treated them as much as we could. So you have to say that about half of our patients fail to respond to corticosteroids. Can we pick out the responses versus the non-responders by the inflammatory markers in the blood? The answer to that is no, we cannot. You see here is the sedimentation rate compared in patients that are either negative or positive during the second biopsy. You see that, of course, as we reduced steroids, the acute phase responses did come back to a certain degree. They stayed under the threshold, what we define, but you see that we cannot distinguish these two parts of the patient cohort. We're now interested in what's happening after 2, 3, 4 years, and I can tell you what we will be seeing, what the data show so far is that there is persistent vasculitis despite all what we do. So vascular giant cell arteritis is persistent, and I'll show you data that it is really an autonomous lesion, meaning once it has made it into the vascular wall, that it is feeling well there and it continues to flourish. It is difficult to treat. It is independent from extravascular inflammation, and it is difficult to quantify. Since we don't have the acute phase responses, they are of very limited value. What are we left with to quantify, and how good is imaging to actually show us whether there is still active vasculitis? I can tell you from pre-surgical PET scanning, we estimate that about 40 to 45% of the patient have a negative PET. Yet when the surgeon goes in there and removes an aorta, we see active inflammation. So I'll give you how important or valuable are the acute phase markers, how important and valuable is CRP, IL-6, and the sedimentation rate. Well, we just did transcriptomic studies on 25 aneurysms of the ascending aorta. And all 25 patients had active aortitis. Otherwise, we would not have spent the effort and the money on doing, transcriptomics on these surgical specimens. And all 25 patients had a normal CRP and sedimentation rate at the time of surgery. And none of these patients was on treatment. So you have to say that a normal acute phase response, a normal sedimentation rate, and a normal CRP is really not very helpful in telling us what's going on. So what is going on? What type of an inflammation is this? Well, there are more CD4 cells than CD8 cells. They sit in the adventitia and in the media, and not so many in the intima. And you see here how these lymphocyte infiltrates are kind of, going to the fences of the distal media. Interesting enough, the lymphocytes that make it into the lesions are functionally very heterogeneous. They produce interferon gamma, IL-17, IL-9, IL-21, IL-2, IL-22, etc. And so you have to say, what kind of an inflammation can this be if there are so many lineages of lymphocytes taking part? A critical element in how this disease can persist in the tissue and go on has to do with immune checkpoints. So you know that when T cells arrive in a lesion or in the lymph node and recognize antigen on the surface of an antigen presenting cell or on the surface of a tumor cell, that they use their T cell receptor to do so. you know that they have go signals coming through CD28 that connects to CD80 and CD86 on the surface of the antigen presenting cell. And you know that there are stop signals too. And one of the famous pathways is the PD-1, PD-L1 pathway. So tumor cells are smart enough to send stop signals to the T cell. They paralyze that T cell. That T cell can really not do anything against the tumor. And you know that we go in and we place a checkpoint inhibitor to disrupt this interaction. We are unleashing and rejuvenating that T cell so that it can go and actually eat the tumor cell. But you also know when we do this that we induce immune-related adverse events. So there must be a balance between these pluses and minuses. And we're just in the process of learning about these balances. So if you go into a temporal artery or into the aorta of a patient with GCA, what you will find is that there is little PD-L1 expressed. So this is transcriptomic assessment. And you see that PD-1 is very much enriched. So the PD-1 cells can make it in there and they can be very happy because there is no ligand. It is as if that patient has a natural checkpoint inhibitor going on. That patient has downregulated that checkpoint. And here are the data on immunohistochemistry to show the presence of the antigen presenting cells that are lacking the PD-L1 and the T cells that are expressing the PD-1. So how important is this checkpoint? And how come that we are now seeing patients that are treated with checkpoint inhibitors in the vasculitis clinic because they have developed aortitis? Well, we can go into the avatar and mimic this disease scenario, right? We can treat the avatar with anti-PD-1 like we would treat a cancer patient. And you see that under these circumstances, the healthy immune system gets access to the vessel wall to some degree. You see that the patient's immune system has great access to the T cell wall already. And if we place a checkpoint inhibitor on top of that, we turn an aggressive vasculitis into a super aggressive vasculitis. And here is how the pathologists read this out for us. So these are arteries, biopsies that are coming out of the avatar, and you see that anti-PD-1 can indeed break immune tolerance. That we see with this checkpoint inhibitor that there are tissue infiltrating CD3 T cells going into a healthy normal artery. So you see that a checkpoint inhibitor for a GCA patient transforms vasculitis into supervasculitis. And we can follow this up, of course, with doing transcriptomic analysis. So, we do single cell or bulk RNA-seq to show that there is induction by these checkpoint inhibitors of a wide variety of inflammatory cytokines, IL-1, IL-6, TNF, IL-23, IL-27, IL-7, IL-15. You see it, it appears. And the checkpoint inhibitor will double the density of the T cell infiltrate measured as PD-1 expressing T cells. And we see the induction of transcription factors that are critically needed for T cells to differentiate into differentiated effector T cells, T-beta, ROR gamma, BCL6. These cells then begin to make interferon gamma, IL-17, and IL-21. Well, in other words, the loss of the checkpoint is one mechanism how to create a broad, multi-lineage inflammatory response. And that's exactly what these patients have. The interesting part is that the checkpoint not only controls the number and the function of T cells going into the tissue, it also controls the remodeling of the tissue. So here we are measuring intimal hyperplasia, and you see we can measure the thickness of the intima, and you see that the checkpoint increases the thickness of the intima by more than 100%. And if we actually go into the tissue and we measure the density of microvessels, so no inflammation can exist without neoangiogenesis, you see that the checkpoint controls this neoangiogenesis. So we have loss of function of the PD-1, PD-L1 checkpoint, which leads to unleashing of these T cells. Is that enough to give autoimmunity? Is it enough if the inhibitory signals fail? Or do the cells of the patient have exuberant activation of the activating signals? So that, of course, would come through CD28, CD80, CD86. And the answer to that is that this CD28, CD80, CD86 checkpoint imprints a metabolic pattern. So that checkpoint controls how much access these lymphocytes have to glucose and how well they can metabolize it. And this is the measuring out of oxygen consumption rate in the cells without and with the inhibition of the CD28 checkpoint. And you see that under resting conditions as well as under stress conditions, the cell now becomes capable of utilizing oxygen much better through that checkpoint. So indeed, this CD80, CD86, and CD28 connection allows the cells to do things in the tissue that they would normally not do and create a scenario of autoimmunity, particularly in the setting where the PD-1, PD-L1 checkpoint is impaired. What does the checkpoint do? I mean, what is it this balanced T cell doing that behaves like this? Well, what it actually does is it begins to utilize glucose to a much higher degree. It begins to be much more inflammatory because we know that the microvascular neoangiogenesis depends on CD28 signaling. You see that if we block in the avatar this pathway, that we can nicely suppress the vascularization of the tissue, and we can nicely suppress the formation of neointima in the blood vessel. See here that under control conditions, patients make an enormous amount of neointima, yet when we take the CD28 dependent signaling away, then this process is contained. How does this work? Well, what we assume and for which we have data, and I'm going to show them to you, is that CD28 signaling controls the T cell turnover in the vessel wall, that it essentially gives a certain degree of autonomy to the vessel wall lesion. How do we know this? So if we block that checkpoint, then you see that the number of T cells in the tissue comes down, that the proliferative activity measured here as a Ki67 index comes down. And if we do FACS analysis in the tissue, we see that a population of what is now called the tissue resident memory T cells is contained if we actually, take away that stimulatory signal. So by feeding the cell metabolic intermediates, this pathway allows in situ T cell proliferation and the accumulation of tissue resident memory T cells. a process that's needed to give the lesion autonomy. So really, this lesion doesn't care what's going on in the rest of the patient. And if we want to really treat that lesion, it is not enough that we stop the influx of inflammatory cells. We have to take the ones that are living in there out. So you know that the pathology of giant cell arteritis is complex. You knew that it has many, many different elements. You knew that they are coming together to form this fascinating network and in a spiral motion lead to disease. So this is another one of these beautiful images from the Webb telescope, this Canadian-European NASA collaboration to show us what space look like and which elements are there. So do we understand this spiraling process that leads to disease in any way better now than we did 20, 30 years ago? The answer to that is yes. And after I throw you into all of these molecular pathways, let me just try and summarize it for you and simplify it somewhat. We do know that there is an at-risk host, and that at-risk host has a very interesting metabolic condition. That at-risk host has low glucose, low lipids, low body mass index. We know that that at-risk host goes into a pre-disease period in which the host loses self-tolerance. We know that the Notch signaling pathway is important both on the regulatory cells as well as on the effector T cells, leading to poor Treg cells and abnormal expansion and differentiation of T cells. We do know that this phase transitions into wall invasion when the vasa vasorum become leaky, and that has to do with these abnormally stimulated T cell finding ligands. I didn't touch on the fact that the patients have monocytes and activated neutrophils that support that leakiness. And we know that when this has happened, it's almost like a point of no return. That once the immune system has found access, it will form granulomatous infiltrates due to a defective PD-1, PD-L1 checkpoint. It will create multiple cytokine-producing effector T cell lineages, multiple macrophage lineages, and it will create tissue-resident memory T cells that will give rise to self-sustained inflammation, to which the vessel wall responds, but which gives us, of course, this challenge of how do we ever get it out again? So what's on the horizon? I mean, how can we look even further into the disease, and how can we actually begin to make sense out of this? Well, on the horizon for giant cell arteritis is the question, what are the mechanisms that lead to this low metabolic activity? And how could this metabolic activity in the 30s, 40s, and 50s of these patients translate into disease 2 to 3 decades later? How does that work? Of course, we would like to know how, when, and where tolerance is broken. You know, where does this happen? Does it happen in the bone marrow? Does it happen in lymph nodes? Where is this happening? It is probably happening in lymphoid tissues. But how, when, and where is tolerance broken? And then, of course, are there immunophenotypes that are associated with pre-disease so that we can filter out the patients that deserve our attention in monitoring them? How does this transition occur at checkpoint 2 into the vessel wall? Can we predict this, and can we prevent it? Can we close the door to the tissue? so that the immune system can't make it there. And if it can't make it there, it cannot cause vasculitis. And then we see all these patients that come to us and they are in phase 3 of this disease process. Acute phase reactants are not helpful to us. How can we measure disease burden and activity? And can we break the autonomy of the lesion? This is like having a colony somewhere. The immune system has built this colony. And how can we break the autonomy of that colony to stop the disease process? So these are the questions that are on the horizon, and I'm certain that the next generation of physician scientists and clinicians will address these. We have gone through this journey with the help of a large number of individuals. Of course, we have had excellent support by our colleagues that have allowed us to have access to tissues and methods so that we could study this disease. We are particularly thankful to the faculty of the Mayo Aortic Center and Mayo Cardiovascular Medicine, because from them, the tissue samples and patient samples have come. And then there is a generation, 2 generations of postdocs that in some way or another helped with giving us insights into the pathogenesis of this disease. And it all could only be done because this work was supported steadily over the last 25 years by the National Institute of Health. So thank you very, very much. And if you have questions, I will be more than happy and try and answer them. It has been a privilege to come to Montreal. And I hope that we can continue this legacy of making great things happen when the US and Canada are getting together. Thank you very, very much.
Thank you, Dr. Weyand. Thank you so much for this fantastic presentation. And I see quite a few questions coming in. We have a couple of minutes left. Congratulations, first of all, on all the wonderful work you are doing. And thank you for this. How do you explain the Black and Asian population don't develop GCA?
Well, if you think about it, that you need, or that the at risk comes from a certain metabolic condition that are really present decades before they ever get GCA, then I think we now have to ask the question, what is the metabolic network in patient populations 25 years before this happens? So this scenario of low glucose, low lipids, low body mass index, that's probably not a widespread scenario, right? It's relatively rare. The Scandinavians have this. And in the Scandinavians, this is kind of the very, very, very early signs of being predisposed to the disease. So I think we need to go to these metabolic networks. How are they regulated? What regulates blood glucose in a 35-year-old? You know, why do some people have higher lipids, higher glucose? Some people have lower lipids, lower glucose. And how does that translate to vasculitis? I think, we're in the middle of this. We're looking at the immune system of these individuals. We have no smart, great ideas yet, but we think it's a fantastic model system to learn how metabolic conditions and tissue conditions can condition the immune system to do something 25 years later.
Thank you for that. So there's a comment question here about different subtypes or phenotype of patients with GCA, whether inflammatory or less inflammatory or cranial. Do these subtypes potentially have different tolerance disruption, different immune activation pathways? And are there patients with a propensity to develop aneurysms different for those who do not?
So let me start from the back. We now make it a routine, of course, to screen every patient for aortic involvement. And the reason for that is simple. most of our patients, sooner or later, will have an element of aortic involvement. An interesting aspect of this is, of course, that our patient population, by the start, when we make a clinical diagnosis, is 75 years old. The time frame for the aortitis is long. So I personally have seen patients that were not diagnosed with GCA aortitis, but had aortic surgery 15 years ago. And by the time they have actually trouble with the next part of their aorta, 15 years have gone by. They have not been treated. They have not been monitored. They come back to us and they need another aortic surgery. So the time frame of progression in the aorta in most patients is slow. So if you're 75 and your aorta fails 20 years later, that's, you got to make it to 95 for actually capturing that, right? So I think this landscape is changing because people are getting older. Yes, the hospitals are now filled with individuals that are in their 90s. And I think that's exactly the reason why we are seeing many individuals that had a diagnosis of GCA and we realize, oh my God, aortic involvement is maybe the rule, not the exception. So whether patients actually, whether there are truly patients that are aneurysm builders versus those that are non-aneurysm builders, I'm not entirely sure. I think that may have to do with disease duration. Are there patients that dissect versus building aneurysms? Yes, and I think they are interested, right? So there are patients who come to us and they have dissection and the aneurysm hasn't really gone that far. They usually have some dilatation of their aorta, but they haven't built these, extreme dilatation of the aorta. So what leads to dissection versus aneurysm formation? I think that's an interesting question.
Fantastic. Dr. Weyand, we're coming up on the hour, so I will have to close the official session, but there are quite a few questions coming into the chat, and I would ask if you can take a couple of minutes to answer the questions that are in the chat. In the meantime, I'd like to thank everyone for participating. Those of you who want to stay on, the chat will remain open and you can look at the questions. Once again, thank you very much. Wonderful presentation, really, really interesting work and exciting work that you and your team are doing. And thank you so much for sharing this with us. And I invite you to please look at the great comments and questions that are currently entered in the chat. Thanks, everyone. Have a wonderful afternoon.
Thank you very much. The chat is in front of me, and I'll try to respond to some of these. There is a comment from Dr. Natalia Dayan. I hope I pronounced that correct. This translational approach and model are so useful for many disease processes. Yes, that is correct, right? The big theme for us is, for our generation, is how can we molecularize disease? How can we come from determining the molecules? And yes, the answer lies in translating. The answer lies in going to the patient. And we need model systems that mimic the patient's conditions as much as we can. There is a question, not all GCA patients have the same phenotype, some most cranial, some mostly LVV, some both, some extreme inflammatory and some less, some with PMR and some not. Subtypes potentially have different tolerance disruption, different immune activation pathways. Are patients with a propensity to develop aneurysms different? So we already touched on the aneurysms. I can say that we have a large study in place, and it would be exciting to actually have collaborators in Montreal that would want to join that study, and I'll tell you what we do. So we have recruited a cohort of first-degree relatives of patients with GCA, which we hope will give us insights into the 25 years before disease onset. We know that there is familial risk. We already know that there are certain immunophenotypes which we see already in the non-affected first-degree relatives. So if you would like to have patients with their first-degree relatives, ideally children, siblings are also very valuable, enrolled into that cohort, we will make that happen. This comes directly to the question, are patients different? So we are also enrolling a PMR cohort, patients that have what we diagnose as PMR, and we follow them by very close immunophenotypic monitoring. As you know, about 5% of these patients per year are transitioning and then are being diagnosed with frank vasculitis. And we hope that in that transition cohort, where we get them from early phase 1 going into phase 2 and then developing phase 3, that we can distinguish different subsets of patients. What are the clinical action points? Hi, Ines. This is a question coming from Dr. Colmegna, and I had the privilege to be one of her early career mentors. You are very lucky that you have her. What are the clinical action points from the data showing persistent pathology after 9 to 12 months of steroid treatment? Well, the first consequences is that you can get a biopsy even if your patient is treated, right? Your likelihood to actually see the disease in a treated patient is very high. So in the first 6 months of the disease, based on these data, you should be able to capture most vasculitis cases. So we take this as a guideline to say, if patients coming to us who have been diagnosed with GCA, there was no biopsy taken, and there was hesitance to take a biopsy because, quote, once you're on steroids, we cannot see the disease. We do a biopsy to actually see whether they have vasculitis or not, particularly in patients that continue to be symptomatic. And you have such patients, right? You have patients that have been diagnosed with GCA based on headaches and a sedimentation rate. They have been treated with corticosteroids plus minus tocilizumab, and now their headaches are coming back, and there is concern that they may have refractory vasculitis. Well, we first need a diagnosis. Do they or do they not have vasculitis? I would say this is a good indication to get a biopsy, because you have a very good chance to see it. There will be certain patients that have turned negative, but by 12 months, half of your patients, despite full-blown therapy, will still have a signal of vasculitis. So I think that is pretty good, right? So I have a very good chance to actually see whether they have vasculitis or not. Do we have similar data from the patients treated with tocilizumab? We do not have a formal study. We do have data from patients that were treated and had to undergo surgery. And in my experience, the disease is persisting particularly in the aorta. We're going to Dr. Ivan Fantis. What is the primary lesion? Is that known? Has VEGF inhibition with Avastin been tried? The primary lesion in the periphery is probably starting about 30 years before they ever get vasculitis. Where is it? We do not know. We can only have suspicion, and as I said, it looks like a lymphoid organ phenomenon. So bone marrow and lymph nodes come to mind. We now know that there is immune system, of course, in other sites, the mucosal sites, the gut, the respiratory tract, etc. Is it possible that the initial loss of tolerance occurs in the respiratory tract or gut? Yes, it would still be in lymph nodes, because from all what we know, tolerance breakdown occurs in regional lymph nodes. So if you say this is a gut phenomenon, it would be gut regional lymph nodes. So I think the likelihood that this happens in lymph nodes is very high. I think the bone marrow is also a site, although not all immune cells love to be in the bone marrow. Okay. Dr. Sasha Bernansky. Thank you very much. It has been a pleasure. The next one is Dr. David Rosenblatt. Have there been any GWAS studies, and are the sample sizes too low? There have been extensive GWAS studies. The best ones, of course, done in countries like Iceland, where the incidence of GCA is high, where you have a pure population and you can actually look at genetic traits. The GWAS studies have all pointed towards the HLA region as the major genetic risk factor. There are other non-MHC risk determinants. We have not systematically looked through these, but I can tell you that we have not seen any metabolic polymorphisms that are linked to what are currently known as polymorphisms that have been fished out by GWAS. Okay, I think I made it to the end. I would like to say thank you again. Thank you very much. It was a fun to be in Canada. Thank you.